I am super, super excited to introduce our host for today, Alice Miranda Olstein of Politico. If anybody else is like a policy political nerd, you all know Politico. So Alice has been with Politico as their federal policy reporter expert. She's been with them since 2018. She's got a long history in this space, so she's going to do a much better job and probably won't talk about domestic animals and ketchup and sauerkraut. So I will be turning this panel over to her. And if you haven't caught it, she also oftentimes can be found on a really cool podcast called What the Health. And I just think that's great, because like everybody comes up here, like you talk about things like, who's going to remember that? You're going to remember now. Go look it up. What the Health. It's one of the best health policy podcasts out there. So without further ado, I'm going to turn it over to the experts over here and Alice, and I look forward to a great morning session. So welcome and thank you.
Thanks so much. Thank you all so much for having us. This is my happy place at the intersection of policy and politics, so this is exactly what I love to talk about. And as you just heard, this has been one of the wildest presidential elections in modern history, and we still have more than a month to go, but throughout all of the twists and turns, and there have been many so far, and I'm sure there will be many more before it's over, we have not learned much of anything about how either candidate would approach Medicaid. Former President Donald Trump has repeatedly vowed to not cut one penny from Medicare or Social Security, but has not said the same about Medicaid. And of course, as we all know, what counts as a cut is often in the eye of the beholder. He has also shown interest recently in repealing the Affordable Care Act, which would impact millions of Medicaid enrollees. But as he said in the debate, he only has a concept of a plan, so we'll see about that. And while Vice President Kamala Harris has rolled out several economic and healthcare policies over the last, couple weeks, not really seeing much on the Medicaid front. So what do we have to look to? We see Democratic and Republican think tanks and advocacy groups, some of them with close ties to the campaigns. They're putting out detailed health policy papers, white papers, manifestos, initiatives. Most famously or infamously, depending on your perspective, Project 2025. And yes, we can glean some clues from those documents, but they are not necessarily predictive of what a future administration will prioritize. So we know the stakes of the race for the White House are particularly high right now because, as we've all seen in recent years, as much or more health policy can be made through federal rulemaking, executive orders, waivers, and enforcement actions than by legislation passed by Congress. So who wins the presidency and who that person appoints to key agency positions will shape the quality, availability, and cost of care. So this is a lot to get through. Luckily, we have two insider experts with us today who can help shed some light. Brian Blase is the president of the Paragon Health Institute, a think tank advocating for market-based healthcare policies. Brian formerly served in the Trump administration as the special assistant to the president for economic policy on the White House's National Economic Council. Before that, he worked on healthcare legislation and oversight on Capitol Hill at the House Committee on Oversight and Government Reform and the Senate Republican Policy Committee. Chris Jennings is the president of the healthcare consulting firm Jennings Policy Strategies. He has done 2 tours of duty in the White House under Presidents Clinton and Obama, in which he played a role in the implementation of the Affordable Care Act, the Children's Health Insurance Program, and other major reforms of government health programs. He spent a decade working on health policy on Capitol Hill and has served as a senior advisor to 10 presidential campaigns. So, thank you both for joining today and helping us work through these thorny issues. I want to start with what broad goals Trump and Harris would likely have for the Medicaid program. So start with you, Chris. On the Democratic side, we hear a lot of chatter about closing the Medicaid gap in non-expansion states, policies around continuous eligibility, the use of waivers, to improve coverage for people, at higher risk or with, unique needs. So what, in your view, would be at the top of the to-do list for a Harris administration?
Well, I think, first of all, hello, everyone. It's good morning. It's great to be in Indianapolis. And, I'm a big Medicaid fan. And what has always struck me is some of the most interesting, innovative work in healthcare comes from the states, and the work that I've had the pleasure and privilege of doing over 30, 40 years, and now my 40th year is doing healthcare, has always been informed and inspired by much of the work that you all do. So first of all, I just want to thank you for everything you do. Secondly, in any Democratic administration, of course, there's sort of the heart and soul of healthcare. It's Medicare, Medicaid, and the marketplace, and the heart is usually Medicaid for a lot of Democrats. You know, they care passionately, and people cry about Medicaid with me all the time. You know, it's like, this is my issue, I care, and that kind of commitment to the program and the people the program serves is really inspiring. And yes, that means that we care a lot about protecting and preserving and then and enhancing. What I've seen, it's just kind of amazing over the last 30 years, and just to see how much more Medicaid has become part and parcel of our healthcare system writ large. And what's most interesting is that there's a commitment by the Harris administration, the Biden-Harris administration, to better integrate all three of those elements of the programs. If we're going to have three big programs, which we absolutely do, there should be more coherence, more alignment, more consistency. And I think that is a commitment that you're seeing from the secretary on down through Chiquita and Dan. I think one thing I think you'll see in this administration, if she is so lucky to be elected, is a real commitment to continuity. And that will include personnel, I think, to some extent, but it will also include policy. Yes, there is a desire to finish the job of covering Medicaid in all the states. How that can be done, we can talk about this. There may be some partnerships with the marketplace to do so. It's been interesting over the last several years how many Medicaid plans have now become part of the marketplace as well. So there's a lot of potential for collaboration there. There needs to be a lot better communication, of course, but I think that's going to be a real interest and commitment to do that. Democrats are very proud of expansion of coverage. We now have more people covered than we ever have had. We don't want to see backtracking. We're concerned about proposals that would significantly reduce resources and therefore undermine states' ability to do stuff. We think Medicaid is a program that you can look at innovation. You see that in things like postpartum care. You see that in reentry programs. You see that in real bipartisan innovations at state levels at red and blue states. I see that being enhanced over a period of time. So overall, I would say protect, defend, expand, empower, will all be very focal points of policy enhancements to the Medicaid program, and it certainly will not be to harm or undermine or to freeze resources. And lastly, I will say, with resources, do have to have over time accountability, and at some point during this conversation, I think we should talk about what that means.
Thank you. Brian, turning to you, we know that outside groups with ties to Trump world, including yours, have been advocating for a wide range of changes to Medicaid, much of them aimed at reducing federal spending. And so what in that world do you see a future Trump administration prioritizing?
Sure. First of all, thank you for the invitation to be here, Alice, with you, and privileged to be here with Chris. Chris is a legend in health policy. He has had numerous successes, so it's really a privilege for me to have the opportunity to do this discussion today. I wrote my PhD dissertation on Medicaid. I got a PhD in economics and have been interested and have studied the Medicaid program for, I guess, 15 years now. I think there's two central problems with public policy with respect to Medicaid at the present time. And I hope that policymakers address both of those problems. The first is it doesn't make any sense for federal policy to have a different reimbursement rate for the expansion population of able-bodied working-age adults and a lower reimbursement rate for state spending on traditional Medicaid enrollees of kids, people with disabilities, and seniors. It creates a whole bunch of bad incentives at the state level, and it harms access to care for those who are traditional Medicaid recipients. I think there's a reason that the ACA was designed the way it was. The ACA passed 10 years ago. It's time to rationalize policy in this area and move to a federal reimbursement that's equal at the state level for those populations. President Obama had a proposal in his budget in 2011 or 2012 called the blended rate proposal. That would have equalized the reimbursement rates. I think that is should be a policy objective to get rid of the discrimination that currently exists in federal policy against the traditional Medicaid recipients in favor of the expansion population. Second major problem that I see is at the root of the federal-state relationship and the fiscal financing gimmicks and schemes that states have deployed on the financing side through provider taxes, through intergovernmental transfers. States spend an enormous amount of resources not on the value of the care through their program. And I agree with Chris, like we have 50 states, states have innovative approaches, and states should have flexibility to try innovative approaches. But a lot of the innovation at the state level is on how to maximize receipt of federal funds. So you have a problem on the financing side. You also have a problem on the spending side with supplemental payments. Increasingly, something called state-directed payments, which run through you all, run through the managed care plans, and are ways that states can get additional money to favored hospitals. The Biden administration issued a rule that allows states through the managed care plans to have state-directed payments up to average commercial rates, exceeding well in excess of Medicare rates. I think that rule is a real problem. It is fiscally irresponsible, and we should not have Medicaid money flowing to hospitals up to the point of average commercial rates. Average commercial rates are 2.5 times Medicare rates, and the Medicaid program should not be used as a financial windfall for politically preferred providers in the state.
So those are the policy fixes that you think are should be in the mix. What of the sort of commonly discussed conservative reforms that you keep hearing about, per capita caps, block grants, work requirements, time limits, how realistic do you think any of those would be?
So I don't think, so I support block grants. I think that we should end the matching grant structure of Medicaid. I do not think block grants are politically feasible at the present time. The House in legislation in 2017 included per capita caps for certain populations, but they were very weak. They were basically ineffective. So I don't see really any proposals out there that are serious on block grants or per capita caps. I do think work requirements, there is momentum for work requirements. The CMS administrator in the Trump administration, Seema Verma, it was one of her main priorities was to allow states to impose community engagement requirements, which could include work, on the able-bodied working age population on Medicaid. I think generally Republicans support work requirements for a broad range of welfare programs. Work is actually good for people. It improves people's health. It improves people's overall well-being. And I do see if there is a second Trump administration, if there is a Republican Congress, I think work requirements in the Medicaid program would be on the agenda.
And I guess for both of you on the work requirements front, since that's, we're even seeing that right now in Georgia, the data from there and the data from Arkansas before, a lot of people lost coverage for who shouldn't have. They fell through the cracks administratively. I guess, yeah. Is that, do you see that as going forward?
Well,
Or is there a way to do it right?
No, I mean, well, in a Democratic administration, obviously, it wouldn't, but it would, and it's like, it's interesting. A lot of Republicans and conservatives are very, very opposed to regulatory burdens placed on businesses and individuals, and yet feel completely comfortable doing it to poor people. It will make it very, very hard to prove that they are worthy of a subsidy for basic health care. It's just something that I think we feel strongly is actually just another administrative burden and largely leads to very complex implementation problems that frequently hurt people that actually, even if you impose the right rules on those populations, would have received coverage, just as we've seen even in the redetermination process. We've seen every time we go through these process, we lose people. And so, yeah, obviously, there's a very significant difference of opinion on the value of these types of requirements. I think Brian is right to say that over time, and I think just to be clear, Brian is talking about the differential matching rates that different programs have within the Medicaid program and the incentives states have to play off of different those things to maximize revenues and even occasionally to discriminate, or not discriminate, but to prioritize populations in different ways. And so, of course, if you look back at the history of why those policies were put into place, is we didn't see states expanding without those enhanced those matches, and states just chose not to do so. That's why that policy was implemented. Having said that, if you look now, we have all the populations covered, and is there a rationale to talk about more consistencies in the matching rates? He may have a point here in this regard. Our concern my concern, who cares about who knows about who the our is? My concern would be, I'm just me anymore, is really using that as camouflage for significant federal cuts to the states. If it's going to be a budget neutral way, or if we're going to do it about reallocating some of those savings to populations that we need to do it, fine, let's have that conversation. But if it's really an approach to significantly reduce federal investment in the state level and shift costs to the states, that's where we would have explicit concerns. Mm-hmm. And can I say one last thing?
Sure.
And we're having fun here today, so it's fine. Which is you're right, Alice, that these issues have not been raised in significant ways during the presidential discussion. Wendy said this as well. There's a real potential threat here to the Medicaid program. If you take off defense spending, if you talk about tax cuts, if you talk about, we've already squeezed discretionary cuts. If you say I'm not going to do Medicare or Social Security,
what's left?
It's just math. Medicaid is going to be targeted. And so it's a very real issue that's not being focused on. It will happen. I can tell you, I've been through it cycle after cycle after cycle. But I also want to acknowledge one thing that underpins some of the concerns about Brian's issues relative to the Medicaid program is, there's a lot of questions about some of the financing mechanisms at the state level. And there's going to be some legitimate scrutiny of those things going forward. And that's appropriate if you're managing any program. So I'll stop with that.
And so, Brian, do you think that some states would unexpand if the match rate was changed for the expansion population? And if so, do you see that as a feature or a bug?
So you're bringing up, you're allowing me to talk about Paragon's paper on Medicaid finance reform. So give me a minute or two to talk about it. So we put out a paper in July. It would be a major reform to the Medicaid financing structure by primarily phasing out the 90% match rate over a decade, so that at the end of the decade, the match rate for the state would be the same as for the rest of the population. For people above 100% of the poverty line, they would all move into the exchanges with very generous premium tax credits. So our policy would reduce Medicaid, but it would significantly increase coverage in the exchanges, and it would alleviate states of the cost for that population between 100 and 138% of the poverty line. Below 100% of the poverty line, there would be a shift in costs from the federal government to the states. I happen to think that is an appropriate shift, that states should bear a greater burden of the expenses so that they are cost conscious and getting better value for their spending. I think a 90% match rate is just too high to incentivize states to get value out of the program. So for that population below 100%, there is a cost shift, and there could be states that don't think that Medicaid is of value to continue the expansion for their state if the match rate is reduced. We talked with CBO, we talked to other experts about what percentage of states we thought would drop expansion, and we estimate it's about a quarter of current expansion states would drop their expansion for people below 100% of the poverty line. But the whole reform would have significant federal savings, over $500 billion and over $500 billion of federal savings over a decade, which gives a lot of space to create programs to help people who would lose coverage in those states, as well as people in non-Medicaid expansion states that don't have health insurance.
And so I imagine there is significant disagreement on that front, but I would want to hear what areas in this space you think there could be some bipartisan agreement, which is often the only way
healthcare in
things
general,
get done.
or Medicaid specifically?
Medicaid specific, although I think in the healthcare space we've seen some interest in other health policy issues too, but it's been very difficult to get anything through Congress recently, and so curious what you think. It's not impossible that we have divided government next year. So.
Yeah, no, I think it's potentially likely.
Yeah.
We shall see. I do think, look, if you look at some of these waiver programs, they're coming from red and blue states alike. Mm-hmm. They've been reviewed and approved by Republican administrations and Democratic administrations. They have different issues in mind. I mean, look at some of the reentry programs that have been really interesting. You have Kentucky and Utah applying for these Medicaid reentry programs. It's very, very interesting to me. I would say it's even exciting. So to me, there are going to be thoughtful programs. I think, look, I guess I would say in Republican Democratic discussions in Medicaid, there's always a conversation about the dual population, right? They have better preventing and managing chronically ill populations. I think there's a lot of mismanagement of those dollars. There's a lot of money in those things. There's a lot of belief in the policy community we can do better. I could see that something there could be done. As I said, I think any administration, Republican or Democrat, who administers the Medicaid program, there are always career and budgetary and policy people who have concerns about some of the financing mechanisms states are using. I could see some scrutiny of those programs more administratively than I see legislatively. I get concerned when Congress thinks about significant reforms of the Medicaid program. One, because it wastes a lot of time because they think they're going to get it and then they usually don't because there's a big formula fight on allocations of who gets what. And I'll go through it because I've done it multiple times if we have to, but let's just avoid doing it because it's just such a pain. Also, I'm concerned, Brian and I had dinner last night, so see, we break bread together. It's a good thing. So, but when we have this discussion of $500 billion in cuts and savings, trust me, they're not all going to be coming back to the states, and there's going to be populations who aren't served, and that means there will be more uninsured populations, and there will be more cost shifting and more uncompensated care and more poor care and more unhappiness. And why go through that? Why? We already have a complicated enough healthcare system, so you're going to have the 3 systems, and then we're going to have some more savings that we're allegedly going to target these additional populations that we just screwed to make better somehow. Enough, people. Let's have a little bit more continuity and coordination and strategic alignment. And then lastly, I just say, Republicans and Democrats, we fight all the time, yes, but the truth is we've had kind of a compromise in healthcare, and the compromise has been, okay, we're not going to have this big government program that is administering everything. We're going to contract it out to private health coverage. That's who you guys are, okay? And with that comes money, and yes, comes regulatory oversight. That's the balance. In every part of our healthcare system, that's what we're doing. When Democrats hate MA because it was a Republican policy, and then Republicans go after Medicaid because it was Democrats, we're still using the same systems. We're having private plans subsidized in some way and regulated. And it's not so different, folks. So let's make it work. So, okay, enough from me.
Yeah, I mean, I agree, making it work and improving the program. I don't think Republicans are against Medicaid. I think there are concerns. I have a lot of concerns about the economics and the results of the expansion of Medicaid through the ACA. But I do think if you want a simplification and to get rid of some of these perverse incentives, it was a proposal from President Obama on the blended rate. So I am embracing a proposal from President Obama on how, now we could probably disagree, we could probably talk about where that rate would go, but it makes zero sense to have 2 vastly different rates for different populations on the program, and a higher rate for arguably the healthier population that doesn't need the higher rate.
Yeah.
Do you think that would be?
That wasn't, I didn't do that proposal, by the way.
He's distancing himself from
But well, it wasn't in the context of huge cuts, so it wasn't you got to contextualize it, but it's a very
It was a budget saver.
It's a very smart debating point. So.
And are there other bipartisan areas of agreement you think could be possible next year if there's a divided government?
In Medicaid? Mm-hmm. I mean, I do think some of the tension in Medicaid policy is federal-state tension, right? It's not Republican-Democrat tension. So Chris and I agree that there are some of these financial schemes employed raise a lot of questions. And I think these supplemental payments and the growth of state-directed payments in particular, like CBO, it's nonpartisan folks in Washington, D.C., CBO, Government Accountability Office, are raising serious concerns about how these work. And I think if you have effective federal management and oversight of this program, which you really need, like there needs to be federal oversight of what states are doing. It can't just be the wild, wild west out there. Then I think there's space there. Obviously, it's not easy to do because there are governors' interests involved and there are healthcare stakeholders' interests involved. And these financial
so many more
schemes,
states have expanded, many by popular vote over the past
I'm not
few
talking
years.
about expansion here. I'm talking about
In general.
the financing schemes, the supplemental payments, the growth of provider taxes. It really is. And so a lot of this money that states get does not go back into Medicaid or healthcare. It just goes to fill other holes in the state budget.
So we all have heard the saying that personnel is policy. So want to hear which folks you think are in the mix to hold key positions in these potential future administrations. Obviously, these, everyone from cabinet secretaries down to the rank and file bureaucrats can really shape what gets done and what ideas are put forward. And so, we're all curious who's going to be the next HHS secretary, CMS administrator, FDA commissioner, all of it. So who do you think we should be keeping an eye on? Who would you like to see?
I'm sure Brian's gonna say this similar thing, that this is so typical. Reporters love this question.
We have to try.
Brian will be a CMS administrator. But I would just say, in the dynamic of a Democratic administration, a couple things. When a new administration, this is a very strange, unique time. You have basically the Harris-Biden administration coming in with the Harris-Walz administration as the new component. And of course, she will want to have her own people, particularly in the White House and in the cabinet. So I anticipate a lot of new faces, or maybe not new, but a lot of new people in those places. There will also be a lot more continuity than we've seen in a new president than we've ever seen before. And you all know, we Democrats, we love to stay in government forever, so most of the people who are there and who are doing, in my view, very, very competent jobs in their agencies are likely to have, particularly under the cabinet level and under the White House, we'll see a significant amount of continuity. There will be exceptions to that rule. I think there are people who are getting tired. I could see the FDA commissioner being new, that sort of thing. But and then the last thing I'll just say is, if we have which is, if you look to the political prognosticators, a Republican Senate, then a Democratic administration has to think about who can get confirmed. Mm-hmm. And so that also helps you filter out, well, who may or may not be. Now, there's going to be some moderate Republicans left, two, I think, maybe, Collins and Murkowski, and maybe a couple others. So there's some room, but not much. And in this very polarized, politicized world, I think you have to make very, very careful decisions. So I gave you lots of information without any names. How's that?
We'll try again later.
I'm also not going to give her any names, Chris. I think Chris's answer was good. I mean, personnel is policy, so let me agree with that. I think the selection of personnel is very important, and it's not just the people that you select for the high-level positions, the HHS secretary and the CMS administrator. There's a lot of roles within the White House that have enormous influence on the way the policy shapes out. So maybe I could just talk about that for a minute. The Office of Management and Budget, extremely important part of the White House. They prepare the president's budget, but the much more important thing that they do is all the regulations that have to get cleared through, and all the administrative actions, they all have to go through OMB. So there is a political appointee at OMB that handles healthcare that has enormous influence. I mean, often they will butt heads with the HHS secretary. Mm-hmm. So that is and the CMS administrator. Where I was, Chris sort of did both NEC and DPC, and I learned last night at our dinner, for 8 years, which is a remarkable achievement to do that for the entire Clinton administration. I did that for 2.5 years. There are 2 policy councils within the White House. NEC is where I was, and that's a very powerful position too. Everything everything really that affects health policy comes through the NEC Special Assistant's desk. So I was able to play a very active role in lots of the regulatory reforms that the Trump administration did. So it's not just the HHS secretary and the CMS administrator. There's dozens of key positions in the White House and in the agencies that a president will fill.
And can I say one other thing? And I should say, I just saw Dan Tsai 2 days ago, who wanted me to send his greetings to you. And, I think this is really important. He came from the state. You want to have people who have state federal experience. And we've seen that, particularly if you're running the Medicaid program, you just need to have some sensitivity to the realpolitik of being able to do policy in this area. And so personnel is policy, but it's also really important. And the experience and the credibility of being able to do hard things really makes it much easier if you have those types of folks, which I think a Harris administration is likely to have some continuity in those areas. I totally agree about the White House that people just don't get. OMB, this PAD, the associate director in OMB, OIRA, who does all the regulatory reforms, the OMB director. Then you have NECDPC, but the chief of staff, if they're the Democratic chief of staff, they have to run roughshod over all these different entities and have some coordinated process where you have options. And then in healthcare, it's not just even the Department of Health and Human Services. There's so many other agencies who have a healthcare interest. So watch the personnel discussion, even though we're not telling you any names. Recognize where those positions are, who fills them, and how they interact with one another, and you'll be far more effective at effectuating, I think, generally more predictable, consistent policy.
I'm gonna try one more time with both of you.
Wow.
Do you here? All right. Approaching it from a slightly different angle. Are there folks at the state level in health policy and Medicaid policy in particular that you think of as rising stars we should all be keeping our eyes on?
Oof. Yes, but I'm not going to say.
Anything? No?
I'll go with Chris's answer.
All right. All right. We'll try. Want to get your thoughts on, obviously, we have another big cliff coming up next year, which is the expiration of the enhanced tax credits for ACA marketplace plans. Obviously, we don't know which party is going to control Congress, and we don't know which party is going to control the White House, but where do you see that going?
You want to start? You want me to start?
I think the election's definitely going to affect the landscape, the political dynamics that affect the extension of the enhanced premium tax credits. There's a lot that expires after 2025. Congress is going to have to legislate in a significant way next year. The individual Trump tax cuts expire, and both parties are going to want to extend a portion of them. Republicans will want to extend more of them than the Democrats. We have done significant work at Paragon on the enhanced premium tax credits, and they're associated with significant problems. They're very expensive. They contribute to small employers dropping coverage, and we've seen a loss in small businesses offering coverage because they don't offer coverage. Workers can access one of these larger premium tax credits to buy on the exchange. But a big thing is the prevalence of fully subsidized or zero premium plans. The expansions created a income group, people with income between 100 and 150% of the poverty line, that qualify for a subsidy that covers the entire premium. We did an analysis that compared enrollees' signups in that income category with the number of potential people in the state, so we did this for a state analysis, that have income in that category, and found that in many states there are far more signups in that income category than enrollees. There are significant incentives for enrollees, but also brokers working with those enrollees to misstate income in order to access one of these fully subsidized plans. Part of it's the complication of the subsidy design. You estimate your income, you then have the subsidy advanced to the insurance company. If you get too much subsidy, when you file your taxes the following year, there's a reconciliation process, but there are significant limits on the amount that the government can recoup if too much subsidy is paid to the insurer. And for people below 100% of the poverty line, there's no recoupment. So we estimate there's 4 to 5 million people enrolled in the exchange nationally that don't have the income that they're claiming in this category. And the magnitude is significant. It's on the magnitude of $20 billion in fraudulent spending just this year. So I think there is a real problem with the expanded subsidies and the availability of zero premium plans. And I would strongly recommend that Congress go back to the original ACA subsidy structure and not continue the enhanced subsidies.
And do you think that's likely if Republicans control Congress? That they will let the enhancement expire,
I think
not renew it?
I think it is more likely now than it has been previously because of all the problems that have been found with what's going on in the exchanges and the extent of the fraud. So it's not, I don't know how likely it is. It's certainly a potential that the subsidies expire, the enhanced subsidies expire after 2025. There's a lot of other options there too. Like Congress, there's in between you expanding the subsidies, keeping them for a decade versus letting them expire, there's a bunch of other things, right? They could grandfather existing enrollees into the enhanced subsidy structure and just not let new people come into the enhanced subsidy structure. You could, the legislation lifted the cap at 400% of the poverty line that had existed in the original ACA. You could restore a cap. But I think the real issue is these zero premium fully subsidized plans just lead to massive fraud and inefficient spending.
And Chris, do you think it's, if Democrats control Congress, the subsidies get expanded, if Republicans control Congress, they don't? Or is there, like Brian was saying, something in the middle, something more complicated?
Well, I mean, the other, in a Trump win, Republican House and Senate, I think it's hard to see it being, it's impossible to see it being extended as it is today. We would try. Can you give us a crumb here? But we would decry. We would try and decry is probably what we would do. I, of course, am working hard to ensure that doesn't happen and preserving America. So I think we're, there is, if you ask most people in political world, I think two things would happen. One, they'd say it's more likely than not that we're going to have divided government in some construct. And two, particularly now, and the reason why I think that is, if President Biden had run, we could have seen a very, very different scenario in the Congress. We could have seen significantly less Democrats being reelected. In a very, very close Harris-Trump election, I think it's more likely that you'll see Democrats take the House, even if she loses. So I think we're going to more likely than not have a Democrat. Now, of course, in that scenario where there's divided government, then I think there is the possibility for, number one, definitely extended, but two, in some contexts. The other compromise might be less years, that sort of thing. You could see there's the shorter term thing. Look, I just want to comment a little bit on the APTC issue. One is that we're talking about people between $12,000 and $16,000 a year. When people, these people are not rich people. We're talking about right over the poverty level. Where is this mostly happening? It's in states who haven't expanded Medicaid. In a shocking development, people at 95% of poverty are aspirationally saying, yeah, I think I can work and be eligible. Otherwise, I get nothing. I get no coverage. That's what it is. So if we want to address this issue, how about expanding coverage in the states that haven't expanded? Okay. Just a novel idea. And then lastly, yes, I do believe Brian is right. There are marketers, there are agents, there are brokers who are misusing this in serious negative ways, and they should be penalized and substantially thrown out of the program. And that is starting to happen absolutely within both CMS activity, and there's legislation on Capitol Hill to do that, and that should be passed and implemented and enacted to the fullest force. But this idea that we're just like throwing poor people off of coverage because they aspirationally tried to get a job to get into eligibility for a subsidy, and oh my God, it's free. Well, if it was like $100 or $50, guess what? They wouldn't purchase it. They don't have disposable income. So, sometimes we just have to call this out a little bit. It's not a disaster. If we really want to deal with cost of healthcare, let's deal with cost of healthcare. And that means prices of healthcare. And that means really doing better in terms of efficiency in managing healthcare. But just talking about making poor people pay a little bit more so they can't afford healthcare just doesn't, it's just not what I think this country should be about.
So it's not just, Chris is right that the problem is more severe in the non-expansion states, but it is, if you control for that, it is much more severe in states that are using the federal exchange than states that have their own exchanges. And that's because the Biden administration has made a decision not to check income for individuals applying through the federal exchange. And what's happened with the brokers in the federal exchange what's been allowed to happen is fraudulent. You have program rules. The program rules should be enforced. It shouldn't be that the law is ignored because people don't like various political outcomes. I think we could talk about what to do on the coverage gap, but that's a different situation than allowing massive fraudulent enrollment. And it's not just people overestimating income. There is also a problem with people underestimating income to get the enhanced subsidy. We do have a philosophical disagreement, it sounds like, on whether people should have to pay anything for health insurance. I think people should have to pay something for health insurance. I don't think it should be a lot for lower income people, but I think there is a benefit in having some engagement and getting some value of the program. And I think we also have this issue of a lot of these enrollees don't know they're enrolled and aren't using any health care. So if you don't know you're enrolled and you're not using any health care, are you really benefiting from the program?
And I guess wanted to have one sort of spicy question given this audience before we open it up to some questions from the audience, which is, do you see a future administration revisiting, questioning, scrutinizing the role of managed care in Medicaid, and should they? In terms of cost, in terms of quality?
I believe that any administration, Democrat or Republican, should hold their contractors accountable to delivering a good ROI on the cost of the care that they, and we're spending a lot of money on health care. We should be getting something out of it. I think that applies both to state financing and it applies to plans. We can do better on quality. We can be doing better on creating incentives. I've noticed in some states now that they are creating financial incentives on plans to work with their providers on very limited number of quality criteria in which there is a much greater emphasis on doing certain things that improve outcomes. And we have huge disparities in healthcare, and we have too many quality standards that we have to do. There should be a consolidation of those metrics. We should be focused on very specifics, and there should be reimbursement incentives to ensure that there's outcomes. And I think we're seeing some very preliminary data out of California, and I think Washington and Oregon, where we're actually seeing some improvement in this area. This is more happening, by the way, in the marketplace than the Medicaid, but I can see it absolutely happening. In this case, in California, it's Medi-Cal, Covered Cal, and CalPERS. We need to have more consolidation, more consistency, more accountability on all these metrics, and I think we can do better. If anyone in this room thinks that we should be bragging about what we've delivered in healthcare for the money, then you shouldn't be doing this. We can do a lot better. We absolutely can. But we also should be proud of what has been done. So, yes, healthcare is an ongoing, never-ending grind, but it's for the right purpose, and it's for the right outcome. And again, we can do better.
So I agree. We can get a lot more value out of our healthcare spending. I'll start answering this question by talking about Medicare Advantage. I think there's benefits of Medicare Advantage, right? It can provide the basic benefit at less, I think 12% less than traditional Medicare, but there's significant problems with Medicare Advantage too. Like it costs, I mean, the MedPAC came out with a report that showed because of favorable selection, if you try to compare, and I think the way MedPAC did it, there might be some criticism, but on a apples-to-apples basis, MA was 22% more expensive to provide than traditional Medicare. That's a real problem. So we should not have managed care if managed care is much more expensive to provide than traditional fee-for-service. I have some concerns on Medicaid managed care. I have seen states, I'm welcome any of you want to educate me on this, but states like Connecticut that have moved away from managed care, that claim significant cost savings from moving back from managed care. I know one of Chris's colleagues, Jean Lambrew, was managing Maine, and Maine doesn't use managed care in its Medicaid program. I see that there's value in coordinating care and what managed care can do, but I am not convinced that managed care has delivered on what we were hoping managed care would deliver when sort of we moved there with both MA and with Medicaid managed care.
I know we're closing up, but I want to say one thing, which is that in the spirit of bipartisanship, that I do believe that there are sometimes legislative vehicles and opportunities to do reforms that are not ideologically based, but are more stakeholder reform. And Brian and I were talking about this last night, which this next year, there's going to be a lot more focus on physician payment reform in the Medicare program. We all know that we can do a lot better on the primary care side of this thing. There is a lot of concern on Republican and Democrat side about how we are paying MA plans, that's for sure. There's some concerns about how we're paying hospitals to some extent. There's also opportunities to change and emphasize primary care more within a physician payment reform structure. And I think that is an example of a policy that Republicans and Democrats can work together on, and actually whomever's in charge can pass and enact legislation that improve things.
Mm-hmm. Thank you. So we have time for a couple questions. We have some mics set up. Please, so we can get to a few, keep your questions brief. Make sure they end in a question mark. We can have time for monologues and debates afterwards. Yeah, would love to hear from a few folks.
I can tell you've done this before.
I have. Yes, sir.
Hi, folks. Tom Bednar with Healthsperian. Great conversation from both of you. Really looking forward to what comes next, certainly during the lame duck period. We had a great panel discussion about that from folks in the room yesterday. One topic that I heard you briefly mention that I'm curious both of your takes on, there's been significant bipartisan interest in duals reform. It's a topic that's come up for 5-10 years in pretty much every circle, Republican, Democrat, nonpartisan. There's the Duals Act right now taken up by the Senate. Curious if you have any thoughts on the future of duals reform in particular. Obviously, it's unlikely that act is going to be passed at the end of this year, but more broadly, if you have any sort of prognostication on the future of duals reform.
You can have
this is one of those areas where we have talked so much about this and not succeeded. I mean, I can remember talking about duals reform for 20 years, so we can't brag about our level of progress here. Obviously, you all know that one of the reasons why we don't do as well sometimes is that there's a perception. I see Matt Salos in here. He's always complaining, we never get credit for the savings that we achieve for the Medicare program. Give us more money, give us more money, give us more money. Okay. I've heard it like 1,000 million times. And, but then there's really also another problem, which is that even when we set up these programs, we don't get participation because there's a lot of people who are concerned about people being jammed into these coordinated care plans and not have access to specialty care and other things. And there are groups and organizations like AARP and others who no, 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 no. The policy that you're talking about in the Senate, I think, is I should be careful about how I say it. I think it's highly unlikely that that's going to be passed and enacted for any time, because they're talking about a whole brand new title, not Medicare, not Medicaid, a brand new title. That's not going to happen. But the concept of having an idea where people have a opt-out as opposed to a mandatory enrollment, but it is an opt-out. It's like you need to choose to opt out of the program, would enhance the likelihood that you could have workable programs through the plan-administered dual-eligible programs, which has been a big problem before, because if you don't have enough participation in these plans, you can't efficiently run them. So, long way of saying there is progress going. I think it's potentially bipartisan. It gets a little bit locked down politically. There's larger insurers right now are not particularly in a favored status in Republican or Democratic world, and it can be demagogued a bit. But I do see some possibility, particularly if it doesn't get reconciled at a geopolitical level, but it's more as a traditional, targeted, smaller policy level. You always do better in healthcare if you're not one of the policies where all the children are in soccer, everyone wants to have a piece of. You want to have just a group of small people who are actually getting something done. A great example of that, by the way, has been these Medicaid waivers on the reentry programs. It really hasn't. Big political people don't even know it's happening, but it's just smart policy, and you want to keep us out of it because we can only mess it up. So I'll stop with that.
Anything to add on duals, or we can go to our next question?
Hi, I'm Claire Horton from Kaiser Permanente. This may be an unfair question, so feel free to not answer it or hedge. But if the two of you could get in a room together for 2 weeks, could you design a system for America that worked and was operationally efficient and was sound policy? Or, in other words, how much is politics getting in the way of policy? Or are the parties so fundamentally apart on key elements of healthcare that would not work?
Well, we started with dinner last night.
Laying the groundwork.
I mean, it's hard because no one would design the healthcare system the way that the U.S. healthcare system is designed, right? And really, so much of it comes down to the employer-based system that's at the heart of it. I would not design our healthcare system based on the way that we have employer-sponsored insurance. But Chris and I haven't had a conversation about that yet. I think we could reach, if you took politics out of it, political considerations out of it, I think Chris and I could design, come to agreement on a set of policy reforms that would be sensible improvements. I mean, we talked about some last night. Site-neutral payments in government programs, for instance, I think would be one. But I don't know. I don't know if we'll get that opportunity to spend the 2 weeks together.
And
Please, no.
even things. We've also seen that even things that have bipartisan support, like the site-neutral payments, they're going nowhere fast. Even with that bipartisan support, it's just really hard to get through.
But I think generally what you learn is that you need to, if you're looking at hard policies that take away anything from anyone, it needs to be done in a thoughtful way that reallocates it more efficiently. And that's hard policy work, but it absolutely can get done. Part of it, you have to get, these were these moments, and Brian he's too young, and he laments that he is, because there was a time when Democrats and Republicans had to work together, and we had targets of savings we had to achieve, and that provided the political pressure for us to be able to do real reforms. And now, ironically, because both parties aren't really constrained by that, that has created, it's made it actually harder to do. But to answer your question is, I think we could make progress. I think if you take away the politics of it, we may have disagreements about how much money people are allocated to ensure affordability or how aggressive we are on cost constraints. But those are discussions that are in the world of the negotiable.
Mm-hmm. Mm-hmm. We only have, let's make both of these short so we can get to them.
Yeah, good morning. Joe Glinka from Highmark Home Care.
She's been saying, stop talking so much, Chris.
I'll shut the mic off.
Lightning round.
In the event of divided government, where do you see the processes of executive order and impacting the Medicaid space?
I mean, significant, right? I mean, it's not so much some of it's the executive order, but it is what's the personnel, and CMS and HHS have a lot of administrative flexibilities. I mean, there's a lot of rules that come out. There's obviously litigation concerns and challenges, and with Chevron being upended by the Supreme Court a few months ago, that could be some restraint on administrative activity. But most of Medicaid, as you know, is run through waivers. Courts grant CMS generally a lot of deference in approving state waivers. The parties will take different approaches to what they want to prioritize through waivers, as well as just a whole bunch of other. A lot of these ACA policies of the Biden administration, I think a Trump administration would reverse and try to tighten up program integrity. So I think there's significant policy ramifications that come out of whoever wins the White House, regardless of what happens in Congress.
And I'll just quickly say, even before the Supreme Court ruling on Chevron, the department's Office of General Counsel has been constantly integrated into any type of regulatory executive action. So sort of this perception that people can't do regulatory and executive actions, I think is probably overstated. That's definitely going to continue, and it will be much better under a Democratic administration. No, I'm kidding.
Last question.
Hi, I'm Jamie Harvey. My company's Agillion. My customers are mainly plan leaders of Medicaid. The problem I hear a lot from them is around network adequacy and the shortages of providers, like in provider deserts. And it's really different from state to state and region to region. So what would a Harris administration or a Trump administration do to make that better in the Medicaid space?
Well, I always find it ironic that Republicans frequently criticize the Medicaid program because of tight networks and inadequate reimbursement to providers, and and then they say, and therefore we're going to cut the program and make it easier to do that. So I someday you can reconcile the magical approach to doing that. But as you know, Democratic administration have tried to provide for enhanced incentives for states to provide enhanced reimbursement rates for primary care, and that wasn't sustained. And ultimately, of course, it is the states who make decisions about reimbursement. We match those rates. And so in a way, I'd say if states really cared about that, they themselves would need to be doing that. And I think the fact that they haven't, I'm just sort of interested in how you say this, Brian, almost suggests that they do feel like they have some, they do feel that they are paying some of these dollars themselves, because they are hesitating to increase reimbursement rates at the state level for sure. So I think it's a real problem. I think you'll see that we need to have more supply of providers, absolutely. If you don't have more supply, you're going to always have this concern. The Congress on a bipartisan level has spent some money to have more slots, et cetera. I think we need to do a lot more job, and I know this is controversial, but I'll just say it anyway. This is Chris Jennings. No one's speaking for anyone else, not anyone else, but most of the workforce that we need for the Medicaid program are likely to come from immigrant communities. in many, many ways. And this idea that that isn't going to be a huge part of our healthcare workforce is crazy. And if we if we rationalized our immigration policy, I think we could do something more on the workforce front too. So that's just Chris Jennings talking. So I'll shut up from there.
So I think top line, there's a lot of money right now in the system, and I think if you look at what the Biden administration has said in my opening comments, these state-directed payments allowing Medicaid payments up to average commercial rates for hospitals suggests that there's a lot of Medicaid money that's going to hospitals, that is enriching hospitals, that could be redirected in better ways for primary care. And that is a lot of the realpolitik at the state level, where hospitals are incredibly powerful actors. And I think this is a role for the federal oversight here, is to get that money to where it should probably be redirected, which is primary and basic care, and out of these huge, massive supplemental payments that are fattening hospital bottom lines. I agree with Chris on the supply and the workforce. Like we should expand the healthcare supply. States should get rid of certificate of need laws, limits on scope of practice, and the like. And I do think, in general, the Medicaid program has grown too large to serve those who really need it well.
I think we're going to have to end it there.
I hate to do this because we would keep you guys here all morning, as you can tell. So want to thank the panel, Chris, Brian, and Alice. Thank you very much. Round of applause. We knew this was going to be the best session of the week, and it did not disappoint, and I would have paid money to be at that dinner. So next year. So thank you, everybody. Everybody enjoy the break. On to the next sessions, and we'll see you all in a little bit.